My name's Christina Regula. I actually, just a little background about me, I got my first bachelor's in human development from Cornell University, and then actually after that I ended up working as a clinical assistant in cardiology. And while doing that, I decided to go to nursing school. So I got another bachelor's. I went to the accelerated program at the University of Rochester, and then I stayed up at Strong and worked there for a couple years in the acute cardiac step down. My husband and I got married, and he got a job back here, so I ended up working in ambulatory care. I originally floated and drove to different clinics. And as you'll see in this, I did wind up in the anti-coag clinic there for reasons of high staff attrition, and they needed some help. So here I am now. So thank you. So today I'm going to talk about high staff attrition in the local anticoagulation clinics. I'll give you a little background, the actual issue, how this applies to the field of nursing, the theoretical framework I used, what literature I found to support my proposal, the actual research question, and then the methods I would use to implement change. So just a little background on anticoagulation clinics or Coumadin clinics in general. So as you know, initially, now Coumadin has been around for over 50 years, and so people have been managed way before the 1990s here, and providers managed it. And that seemed to run pretty smoothly, and then times got more demanding, and patients got more complicated, and they didn't, being able to have nurses and pharmacists help manage was a big help. And studies that have been done from Nursing Economics, the Journal of Managed Care, or American Medicine of Managed Care, they showed that actually pilot studies that were run for nurse-managed and pharmacy-managed Coumadin clinics, the patients actually fared better. They had more time in the therapeutic range. So that kind of took off nationally, and now that's what we see a lot of. So locally, what happened? Locally, the healthcare system I'm talking about initiated a pilot program in 2000, just with one of their ancillary clinics, running a Coumadin clinic there. It did well, and they applied it to the whole system. And as far as staffing, they initially staffed them with office assistants, medical office assistants, MOAs. And then over the next few years, New York State, along with other states, but we're going to focus on New York because that's what triggered this whole issue here, changed its regulations, and MOAs were no longer allowed to practice. They felt we needed to elevate the scope, and then LPNs back in 2006 began managing. And then just in 2009, we had another regulation change. And New York State came in and said that mostly due to the assessment portion, LPNs could no longer work in Coumadin clinics, and it needs to be registered nurses. And that's where this issue begins. So here's the regulation change in March of 2009. So what happened? All right, so again, now it was a challenging situation. The LPNs have been doing a wonderful job. And the patients, you had a great patient-nurse relationship going on, which you do need in this role. You need the patients to be honest with you. They need to be comfortable, because diet changes, extracurricular activities, just the honesty of, I had a beer last night versus I had a six-pack last night. But you need that, and if you don't trust the nurse that you're talking to, you're not going to get that, and then their Coumadin management is going to be incorrect, and they're going to have either bleeding or thrombotic issues or hospitalization. So it just escalates from there. So initially, what the organization wanted to do was continue, keep the LPNs employed, and try and add on an RN at each site and have them oversee everything. So they did a pilot experiment with that for about a year, and the RN was way too stressed, basically saying she felt like or what she pretty much was, she was signing off on about 70 charts a day and maybe seeing 20 patients, So it was just a very unsafe issue. So they changed their plan and decided to just completely switch over to all RNs, and which meant they didn't need to lay off the LPNs. So again, a difficult transition. All right, so they transitioned, and the transition happened quite quickly. And again, most of the LPNs that were already employed had been there 15, even 20 years. So there wasn't actually much discussion about how to do it. Reviewing the orientation checklist. It was kind of assumed, okay, well, they're already practicing. You can just plop a nurse in another role, and they know what to do. And that was kind of a big assumption there. And there was only one trainer, and it was the Keuka Clinic coordinator for all 6 clinics. There are 5 in New York State. And so her time was definitely spread thin, and the resources were spread thin. So it didn't work out so well. They all left within, at the 2 clinics, all RNs resigned within less than 6 months of being hired. So why did this happen? And it's just going to escalate and snowball, and the patients were having more issues and more questions. So this really we need to figure out why this happened and resolve the issue so it will not happen again. So in order to reduce further staff attrition, we need to identify and hopefully correct the issues leading to it. Okay, so my research question, so for newly hired RNs in the Keuka Clinic, does increasing training, and I'm saying increasing training to 3 weeks because the original training period that they had was, they said 2 weeks, but truly that was inconsistent. Every RN that I talked to, again, the needs assessment was done via informal conversation, working with them. I was like, you're just kind of talking about, so what's going on? And so again, they said they would receive 2 weeks of training. Some did not. Some received about 7 days. Some did not receive training at the same clinic. Some received it at the main clinic. Others received it at the clinic they were going to work at. So it was very scattered, very inconsistent. So I'd want to increase the training to a minimum of 3 weeks. Require a formal training course. The University of Southern Indiana offers an online 6-week course. It costs $500, and it's 1 day a week. It consists of quizzes, tests, case studies as well, to actually receive your certificate for community management. And again, to be paid for by the organization, not the employee. And additionally, review the orientation list and communicate between the new employee and the coordinator. The coordinator held on to the orientation checklist, and basically once she was going through the training and she observed the new employee complete a skill, she would check it off. So the employees were like, oh, they may have not actually been completely competent, or I should say comfortable in that skill, yet it was already checked off. So to break it down to PICO, by population are newly hired RNs in the Keuka Clinic. The intervention is the 6-week formal training course online through the University of Southern Indiana, increasing one-on-one training or on-site training to 3 weeks, as well as revising the orientation checklist and increasing communication, compared to the current system, which lacks any consistency really, and was pretty much we just need to hurry up and get people trained and get everything running again. And the hopeful outcome would be to improve RN retention and satisfaction. So how would I do this? I needed to think, well, what is the normal training? What do other clinics provide as far as training? I needed to figure out I needed to compare and contrast our clinic with others. Evaluate any relationships between training and staff retention. Based on that, implement maybe a pilot study, increasing the training, the formal course, and orientation, and if that worked out well, hopefully spread it out to the whole clinic. So how does this apply to nursing? Why do we care? attrition in general, I know we're just talking about, I'm talking about the Coumadin Clinic, but in general, it's a huge monetary and emotional cost. A California hospital calculated that attrition of just one nurse, one medical surgical nurse, resulted in a cost of $42,000 in the facility. By decreasing nurse turnover by just 3%, it's possible to save a facility $800,000. And then cost of staff turnover can average 150% of the base salary of the replaced employee. So you really do want to try and keep your employees. This was a special situation where they were regulated to hire new employees, but we want to keep the new RNs there. All right, and specific to the Coumadin Clinic, we have lack of experienced employees. We may have declining patient care because lack of comfort in the underlying training. If we have that, we're going to have bigger issues, bleeding, thrombotic events. Again, I already noted the nurse-patient relationship will suffer. You need that comfort there. You don't have it, you can't, you're basing your dosing on what that patient is telling you. And if they don't trust you when they're lying, they are compromised. And difficulty for patients to continue adapting and confiding in the ever-changing staff. You don't want to go to your provider and see someone different every time. You want to go to the same person. So, God bless you. I used Callista Roy's adaptation model, and I think this was very appropriate for the situation, considering it was a change. And change can be difficult. It was a huge transition, and we need to figure out how we can improve it. So it's very similar to the nursing process, assessing and applying a diagnosis. So the new RN staff coming in needed to adapt to the new position. Most of them said they took the position, if we go to the stimuli, because of the hours. Again, it was daytime hours, no holidays, no weekends. That was a huge benefit. A real improvement in the quality of life was the goal. And instead, what happened was they had what they felt was inadequate training, which led to a lot of overtime, which actually led the facility to paying, more costly in the end. And there was lack of staffing. Now, they would have a per diem or part-time person usually at each site, and the initial goal was to get all the full-time people hired, and then they'd work on getting any per diem or part-time. Well, in that interim period, when you have the new full-time people, there was absolutely nobody to cover any sick time, vacation. It was constantly rejected. They couldn't leave. They couldn't have a day off. So that was a huge, quality of life deficit there. So the quality of life deficit related to work burnout, as evidenced by chronic overtime, employee complaints, and attrition concerns. So the initial staff that had resigned did go to management twice, and management did make some changes. The first change was to the master schedule. Initially, there were 15-minute slots for each patient to be seen, and they adjusted it to 20 minutes, thinking that would help. It did slightly, but you still have to see the same amount of people every day, so they ended up just double booking or triple booking spots. So it really didn't take care of the underlying issue. And they did have paper charts, so they did eliminate that and just continue the strict EMR recording. Again, taking a little bit of chunk off of documentation time, but not enough. That was kind of pretty much towards the end when it was decided they were going to leave. It failed, and we lost those RNs. And then we were shifting a lot of the staff that was left, including LPNs, around trying to cover all these clinics. So again, with Callista Roy's model, if you shift some of the negative and positive stimuli, so you have more positive stimuli, the idea is to retain the staff then. So in this case, all right, you can see the negative stimuli outweighed the positive, and they left. So we need to switch this and get them to stay. So just locally, just dealing with this healthcare system, again, I mentioned that there were 6 clinics altogether. 5 of them are in New York State. Okay? So of the 5 New York State Coumadin clinics, 3, they were all hiring, but 3 were able to quickly hire a new RN staffing, completely turn it over. Within, it was 6 weeks actually. Hired the RN staffing, and out of those 3 clinics, only 1 maintained any RN stability. So the other 2, they lost all their new RN staff within less than 6 months. Now, why did she stay? How did this clinic maintain this RN? They had an LPN who was employed there part-time, and no one had filled her position yet, so she was still there. And she was there for 4 months working beside this new RN. And that's the only RN that stayed, the one who had the LPN with her for 4 months. So I feel like a pretty strong relationship there. And that was just locally. So nationally, what do other clinics do? What is their training program? What's their retention? So Health Care's Ministry in Wisconsin, they have 2 clinics, and they do require the formal training. Oh, there it is, okay. They take a 40-hour accredited course through the University of Southern Indiana to become certified. So this clinic requires it. And this one isn't, but this is in Marshfield, Michigan, and they require it as well. And this is just an overview of the cost of the program and they require. So compared to what the local clinic offers, where we had the attrition. So again, the 2 weeks, which was kind of inconsistent. We do have the point of care testing on the machines. The ACS medical director provides a pre and post test, which you'll see I would continue for all the new hires. And then after the 2-week orientation, the new hire must have a passing grade on that to be able to kind of be released in practice. So just to cover, which I didn't in the beginning, I apologize, there is an algorithm provided that all the nurses work off of. So if their INR is 1.5 and they're this age and this is what happens, this is what you do. If they're between 2 and 3, this is what you do. Everybody get the idea. And if they're on it for AFib versus if they're on it for valve replacement, pretty similar to a lot of the algorithms that are already in place. But just so you know, it's not completely, but they follow an algorithm. Okay. So literature review. So I wanted to see, are there relationships between more training and staff retention and staff satisfaction as well? So this was a qualitative study performed at 6 VA Coumadin clinics. It was a blind study, so the sites, the subjects, the employees that were being interviewed and observed were unaware of their status, if they were a top-rated clinic or a low-rated clinic. They had the same observer and interviewer at each clinic. They spent 4 hours observing at each clinic, and a total of, there were 55 interviews. And you'll notice, so these are the top-rated clinics. They did a thematic analysis coding for just some themes that they saw and comparing the top-rated and bottom-rated clinics. So 1, 2, and 3 right here are the top-rated clinics, and then 4, 5, and 6 are the bottom-rated. And you can see the top 3 rated clinics, they perform quality assurance, they have access to clinicians, experienced resources on site, they use evidence-based practice, they felt they had adequate training, and they have adequate staffing. Okay, they have everything. So now the bottom 3, let's see, they do have accessible clinicians, they felt they had good training and experienced resources. All right, they did lack the staffing, and during the interview, some of what people were saying, employees at the low-rated clinics were noting that they felt rushed and that they wish they had someone on site to go to. They felt that their schedules were jam-packed, they were double and triple booking, and they were not satisfied with their job, so as you can see with that. So staffing and training and having experienced resources there and accessible clinicians does make a huge difference. Another study done, this is not specific to Coumadin, but it's quite impactful. In California, this was a study done implementing, it was a pilot study, implementing a mentorship program for new RN graduates. And it was implemented at 4 different acute care facilities. It involved nearly 500 nurses who were mentors, and they took on mentees. It's a longitudinal study that was performed over a 3-year period, and they wanted to see the cost savings before and after implementation, as well as the attrition rate. They were having major issues with high attrition, mostly from the new graduates coming in. So they did a mentor-mentee relationship, and you can see it was a huge benefit. Having someone to go to, having that experienced resource made a huge difference. Look at this cost savings here. Before, when we had $100,000, and then we're at $50,000, and the percentage difference from about 22-23% attrition down to about 6 or 7%. So a huge improvement. So looking at the strength of the evidence, again, so the VA study, it was blind. It was only single blind, so the interviewer knew. But having the same interviewer at each site will attenuate the bias. They did have a strong data analysis with their thematic coding. It provided only qualitative data. And Mills and Mullins, so the mentorship program, that was a strength. It was a longitudinal study. It had a large sample size of 500 nurses. And again, they actually had hired outside evaluators to evaluate their evidence, which attenuates a lot of bias there. And it was in mixed methods. So you have the hardcore numbers there, as well as the qualitative data. And they spoke to both the mentors and mentees, and both. They were a little surprised that the mentors actually found it so emotionally beneficial as well, but they did. And both mentors and mentees noted that they had a higher respect for their job, and actually had a higher respect for the new nurses, which was really great to see, because we really need that. So in general, from that, you can see that increased training and having an experienced resource really did improve retention and greatly cut down on cost. So based on that and the needs assessment from the local clinic, the goal is staff retention, as you can see in the center here. Again, what I've already mentioned, I'd increase the formal training with the online course. More one-on-one training time. With this, I would also propose that we would expand on who could train, so we're not just limited to the one resource of the coordinator. And again, I know it's going to be difficult now because we have newer people in place, but there is still one clinic that is not New York State, and they do still have LPNs that have been working there for decades, who could at least help out, and we could just have the RNs transferred to that clinic to train, so it's uniform, there's some consistency with the training. Revamp the orientation checklist and get both the coordinator and employee on board. I would run a pilot program just at one of the clinics to see how it does. I do that for 1 year. If it performed well, I would hope to expand it to all the clinics. Again, applying Calista Roy's model. So the goal is we're trying to transition some of that stimuli. So we had the previous collapse of the RN staff, and we know why. They felt inadequate training, too much overtime, lack of staffing. So what do we want to do? We're going to implement that pilot study and see if this helps. All right. So we want to. We have new staff hesitation in the clinic, increased patient wait times, and reliance on experienced staff at other locations. So really, what's still happening is we need to expedite the whole training and transitioning of staff and get more new RNs back in, but that's a lot of pressure on these new people that you're bringing in, and it might just cause the same effect. So we need to make sure we revamp the training process. So the goal is to complete the hiring process with retaining the staff, okay? And we do not want to repeat any attrition. The intervention this time is the pilot program that I just mentioned. And I do have good news with this. I was actually able to propose it to the Keuka Clinic coordinator. She pretty much shot down the idea of the company financing the $500 course for everybody. But training was increased to 3 weeks, and it is all done at the main campus. So at least at the one clinic, so they're still working on the other ancillary one, but there's been partial implementation, and they were able to hire 3 new RNs at the one clinic, and so far the one who they hired first, she's been there a year now, so it's been 12 months. So that's just partial implementation, but we did see just with the one change, and she did communicate more with the orientation checklist, that we have had increased staff retention. So my design, again, you already saw a little implementation there. Now I could go to administration regarding the course. Again, some of the staff feel they'd like to take it because it would just help, it would just be good to have, and the more knowledge is better. As of now, talking just to the coordinator, basically if the employee wants to pay for it themselves, that would be great. But so I could go to administration. That would be the next step here. So I want to get qualitative and quantitative data. Again, my sample are the new RNs that are hired. So I need a couple different instruments. I would need to look at the Keuka Clinic staff attrition rates. The company does use Press-Ganey for patient and staff satisfaction. So I would be able to review both the actual numbers as far as the attrition rates, and look at the staff satisfaction. What are their comments? How do they feel? Did they feel they had good training? So there's my qualitative data right there. And again, continue the ACS director's test, the pre-test and post-test, and see with the increased training, is there more knowledge in the end? Has that improved? And again, analyzing it, again, just comparing the before and after, looking at both the actual numbers with the retention and their commentary, and the pre and post test. So the one-year pilot, again, pretty much the same thing, the pre and post test comparison, review attrition rates, and review staff satisfaction. In conclusion, I know I was very specific to the Keuka Clinic, and I did mention the acute care facilities that a pilot program was implemented in California. In my literature review, I found, oh my goodness, like over 500 articles just about how important training is, regardless of profession. Just to take a couple quotes from, according to Strategic HR, formal orientation programs correlate with longer staff retention, and coaching is the #1 factor, contributing factor to performance. And good training is just an excellent retention tool. So, again, it doesn't really matter what profession you're in, training is really key. Does anyone have any questions? Thank you.